with a slight emphasis on Japanese encephalitis as because the monsoon has already crossed the courtyard. To start with, acute encephalitic syndrome is a term which has been coined by National Vector-Borne Disease Control Program. They usually wanted to cluster clinically similar neurological condition in children. And the case definition of acute encephalitis syndrome is at any time of the year, a child coming with acute onset fever. By acute onset fever, we mean fever of 5 to 7 days duration with a change in mental status, which might range from confusion to coma, with or without new onset seizure. But these seizures should not be simple febrile seizure. As all of you know, in simple febrile seizure, you are going to regain your consciousness within 30 minutes. There are two very important issues in this definition. First of all is the change in the mental status should not be explained by fever. Number one. And number two, the seizure should not be simple febrile convulsion. So the causes of this acute encephalitic syndrome, one of the major chunk was Japanese encephalitis, and which is also an epidemic or endemic epidemic encephalitis. And there are other non-viral, non-Japanese encephalitis, which included herpes simplex virus, Entero virus, dengue. There was Nipah virus, varicella, measles was there. And there are some other causes also, like cerebral malaria, scrub typhus, acute tuberculous meningitis, and even this acute encephalitic syndrome is not only caused by bacteria, virus, protozoa, or rickettsia. It can be also caused by toxins and poisoning also. So it is a huge amount of causes which might be responsible for this acute encephalitic syndrome. So when they studied the causes, in 50% cases, no cause was found, and where cause was found, three diseases headed the list, which included Japanese encephalitis, strep typhus, and dengue. And of the three common causes, Japanese encephalitis and strep typhus constituted 16%, whereas dengue 5.2%. But because the surveillance was conducted in those states where Japanese encephalitis vaccine or endemic state was given, so the number of cases of Japanese encephalitis was a little bit lower. But if you take the whole country as a whole, it will be much higher, and it will be much higher than scrub typhus. So with this introduction, I'll go to my case. A 8-year-old boy who had a history of fever for last 5 days with occasional vomiting. He presented to the emergency department with generalized tonic-clonic seizure, which was aborted with diazepam. After the seizure, he had shallow breathing with doubtful neck stiffness. He was not responding to commands. His reflexes were depressed, but his pupils were normally reacting to light, with the left eye slightly deviated to the nasal side. So what is your provisional diagnosis? So again, it is a case of acute onset fever only for 5 days, followed by change in the level of consciousness. And also the child has a generalized tonic-clonic seizure, after which the child was not responding for a long time. So definitely it is a case of acute encephalitic syndrome. But when we say acute encephalitic syndrome, we don't only mean encephalitis. It is rather a meningoencephalitis, because this encephalitis, meningitis, these are not watertight compartment. One can involve the other. So most likely it is a case of meningoencephalitis. So next important question arises, what is the single most important test you'd like to do for the diagnosis? The single most important test in these cases will be a CSF examination. But if there are contraindications to CSF examination, in many places an MRI or CT scan can be done. But unfortunately, most of the places, they don't have facilities for MRI and CT scan. And also you have to transport the patient for taking the CT or MRI. So LP is the single most important test in these cases. So the senior resident was hesitant to do LP because there's slight shallow respiration and slight deviation of the left side of the eye. So whether it is justified and what are the contraindication of doing LP. Whenever you come across a case of meningitis or meningoencephalitis, there will be certain amount of raised intracranial tension. Raised intracranial tension is never a contraindication of doing an LP. It is the impending cerebral herniation when you don't do an LP. So what are the signs of impending cerebral herniation? If the child has abnormal respiratory pattern in the form of arrested respiration, ataxic respiration, or chain stroke respiration, if his pupils are unequal in size and not properly reacting to light, if there is an absence of brainstem reflex, what are the brainstem reflexes? Corneal reflex, oculocephalic reflex, gag reflex, these are brainstem reflex. If they are absent, also you don't do an LP. And if the child has a decerebrate or decorticate posture. And besides that, if the child has a cardiopulmonary compromise, or the place where you are going to do an LP, if it is infected there, and a relative contraindication if the platelet count is too low. And also you should remember, in case of meningoencephalitis, there is a diffuse inflammation of the brain. The forces that trying to push the brain down is counteracted by the forces which are trying to push the brain up. So chances of herniation in case of acute encephalitis is very less. So what are the empirical treatment you will give, and why? So if you see the cause of acute meningoencephalitis, the bacterial causes which are treatable, heading the list in an 8-year-old boy will be first pneumococcus. This will be followed by meningococcus, then mycoplasma, rarely streptococcus pyogenes. And if it is a hospital acquired infection or the child is immunocompromised, then you can think of gram-negative enterobacteriaceae. So if you want to cover all these bacteria, you shall start with ceftriaxone. And of the viral causes, herpes simplex virus is amenable to treatment. So we give a combination of ceftriaxone and acyclovir. But now we have seen the meningitic strains of pneumococcus are not only highly resistant to penicillin, but they are also resistant to ceftriaxone. So now it has been suggested that all cases of meningitis should receive a combination of ceftriaxone to vancomycin. If there's a chance of mycoplasma, how do you understand is the mycoplasma? Multi-system involvement, uh, meningobulbitis, or if the child has skin rash or anemia, then you can add a microlide. And in these days of increasing scrub typhus, many people will also add doxycycline. But at least these three things should be given: ceftriaxone, vancomycin, and acyclovir. So next day, the investigation results has come. Hemoglobin was 9, total count was 11,400 with 62% neutrophil. CRP was 30, slightly raised. Platelet was nearly normal, 1,70,000. Sodium and potassium was normal. And LP was done, which showed 50 cells, predominantly lympho. Glucose was 35, concurrent blood glucose was 50. Protein was slightly raised, normal range is 40 to 80, it is 98. Gram stain was negative, culture report pending, and malaria parasite was done, it was negative, and dengue was negative. So what is the diagnosis at this juncture? We all know, in case of bacterial meningitis, there is pleocytosis, but neutrophilic pleocytosis, with glucose usually less than half of concurrent blood sugar, and protein may be slightly raised. But here the cell count is only 50 with predominant lympho. In case of tuberculous meningitis, you have a raised cell count in the tune of 200, 300, maximum 500 with lymphocytic preponderance. Glucose is low, but it will never go below half the concurrent blood glucose, and protein is usually raised in the tune of 200, 300, or at the most 500. And in case of viral encephalitis, the cell count varies from few to thousands. The protein is either normal or slightly raised, but in case of severe necrotizing encephalitis caused by herpes simplex virus, protein can be much more high. Glucose is usually normal, excepting in mumps meningitis. So at this juncture, the diagnosis is most likely it is a case of encephalitis. It is not a case of bacterial meningitis or tuberculous meningitis. And what do you mean by encephalopathy? Encephalopathy is a diffuse dysfunction of the brain caused by systemic metabolic derangement, usually outside the brain. To cite an example, if the child has a, say, diabetic ketoacidosis, because of this ketoacidosis, he will have diffuse dysfunction of the brain. If the child has an uremic encephalopathy, because of the high blood urea, he will have encephalopathy. So encephalopathy will also cause dysfunction of the brain, but it is due to causes outside the brain. So the next morning, the child is still drowsy and was depressed reflexes. The plantar was flexor. On careful examination, there was no scar, no skin rash, few discrete palpable cervical lymph nodes, less than 2 centimeter, and no hepatosplenomegaly. The child was sent for MRI, report expected in the evening. In cerebral malaria, the parasites are sequestered deep inside the capillaries of the organ, and hence often MP is negative. So can it be a cerebral malaria? Of the clinical syndromes which defines severe malaria, three important are cerebral malaria, severe anemia, and metabolic acidosis. There are three most important presentation of cerebral malaria. One is impaired consciousness. The Ballantyre score is less, either 2 or less, or prostration. By prostration, we mean the child was able to sit up, but now the child is unable to sit up. And if the child is too young to sit up, the child is unable to drink or feed from the mother's breast. Or it can present with convulsion. Convulsion can be generalized, it can be focal, it can be single, recurrent, it can be even subtle. But one thing is sure, the convulsion is irrespective of the age of the child, the degree of fever, and the duration of fever. And unlike cerebral, in simple febrile convulsion, you don't expect the consciousness to regain shortly. It will take a long time to regain consciousness. It has been seen that the early stages of malaria parasite in falciparum malaria, that is ring stages, are found in the periphery, whereas the late stages, trophozoites and seasons, are usually deep inside the capillaries. A skilled microscopist in ideal condition can pick up parasites as low as 10 parasites per microliter of blood. And whereas in field condition, it goes up to 100 parasites per microliter of blood. The single most important cause of not detecting parasite is inadequate examination of the blood film, the duration. To find a parasite, you have to examine quite a good number of films. But these days, hardly people has time. Another very important cause is that we only examine thin film. We don't examine thick film. For detection of parasite, it is the thick film which should be examined, because thick film contains more blood, so chances of detecting the parasite is high. And in thin films, we identify the type of parasite. But unfortunately, these days, nobody examines a thick film. So that is the single most important why we don't find parasite. And also, if the child has been given any anti-malarial drugs, then you might not find parasites in the peripheral blood. And regarding all the parasites are deep inside the capillaries, the parasite develops in broods or batches. You have parasites at different stages of development. Theoretically, it has been often suggested that all the parasites belong to the same stage, but practically it is never seen. So whenever you suspect cerebral malaria, you should see the epidemiological setting, whether such cases are occurring in the vicinity, what is the time of the year, whether it is monsoon. You can go for clinical clues, splenomegaly. Usually in malaria, you have symmetric CNS finding. And if you take the trouble of doing an ophthalmoscopy in cerebral malaria, you can find this finding. These are patchy retinal whitening. These are nothing but sequestered parasites blocking the renal blood vessel, retinal blood vessels. So this is highly pathognomic. And if you can find this, you can tell the child is suffering from cerebral malaria. Enterovirus is another cause of encephalitis. Can it be an enterovirus encephalitis? There are mainly two types of enterovirus. One is Coxsackie and Eco. Enterovirus causes a wide range of disease, starting from undifferentiated fever, which you cannot recognize unless and until you do a viral study, or it can cause diarrhea. Again, it is not recognizable. It causes very characteristic skin manifestation, which are almost pathognomic. One is hand, foot, and mouth disease. Another is harpangina. Here you can see the hand, foot, and mouth disease. Hand, foot, and mouth disease. And the very important thing in enterovirus spreads by fecal-oral route. So where the drinking water and the sewage is side by side, there you get enterovirus infection. And there lies the importance of taking the history about what type of water the child consumes and what type of sewage drainage the child has. Regarding the central nervous system of enterovirus causes more of aseptic meningitis. It usually doesn't cause encephalitis. And if it causes encephalitis, enterovirus has a predilection for the brainstem. It is rhomboencephalitis. It involves the brainstem. And all of you know the brainstem contains the vital centers, respiratory center, cardiovascular center. So it has a devastating effect if it involves the brainstem or rhomboencephalitis. In the Guangxi province of China, a series of deaths was reported in 2018, and it was published in our journal Indian Pediatrics, where the children died due to this enterovirus encephalitis because of neurogenic pulmonary edema. Another disease, this COVID, they also causes involvement of the lungs. But here it is neurogenic pulmonary edema, whereas in COVID, it is due to abnormality in the hemostasis in the pulmonary vessels. And another important thing about enterovirus, that enterovirus also involves the cardiovascular system. It is one of the main cause of uh, pericarditis and myocarditis in case of cardiovascular system. So whenever you come across a case of a hand, foot, and mouth disease or harpangina, you should tell the parents that they should look for these two complications which might develop, though fortunately they are very rare. So can it be a dengue encephalitis? So we know that dengue is a arbovirus. It causes hemorrhagic fever, but why it is implicated as a major cause of encephalitis in the countries? Arbovirus are diseases transmitted to the susceptible host by the bite of mosquitoes, ticks, or sandflies in our country. The three most common arbovirus which we come across in the country is chikungunya, which is an alpha virus, which is transmitted by Aedes mosquito. Dengue, it is an flavivirus, which is transmitted by also Aedes mosquito. And Japanese encephalitis is also a flavivirus, which is transmitted by Culex mosquito. All these three arbovirus, they have a characteristic presentation. They start with a systemic febrile illness, which is indistinguishable from any viral illness. And thereafter, they will manifest their pattern. Every disease has its own pattern. In chikungunya, it will be the arthralgia or arthropathy along with hemorrhagic manifestation. In dengue, it is an hemorrhagic form. And in Japanese encephalitis, it will cause encephalitis as the name suggests. So diagnosing these three conditions in the early stage, in the during the stage of systemic febrile infection is little bit difficult. But if your suspicion is high, dengue has two very important characteristic feature. One is retroorbital pain, another is intense headache, another is intense pain, myalgia. So much so is the pain that we dengue is also called as a break bone fever. Along with that, early in the stage of the disease, you can have leukopenia to be followed by thrombocytopenia. The hemoglobin is relatively high, and so also the packed cell volume. So actually, dengue is not a neurotropic virus. In majority of cases of dengue death, when brain biopsy was done, only in very few cases dengue virus was detected in the neurons. Actually, dengue causes more of encephalopathy rather than encephalitis. There are numerous causes why dengue can cause encephalopathy. Cerebral hypoperfusion, because of the deranged hemostasis, there can be intracranial bleed. Dengue involves the liver, so there's a high chance of hepatic encephalopathy. The capillary leak causes cerebral edema. And finally, to ice the cake, dengue causes very severe electrolyte abnormality, and hyponatremia can cause deranged electrolytes. So all these causes can lead to dengue encephalopathy rather than dengue virus causing encephalitis. The most common cause of sporadic encephalitis is herpes simplex. How do we diagnose and recognize herpes simplex? Every devil has his own den, and we know the herpes simplex virus, it involves the frontal, temporal, and limbic system, and accordingly the signs and symptoms develop. They have olfactory, gustatory, speech abnormality, and because of the involvement of the limbic system, they also have behavioral abnormality. And all of you know the herpes simplex virus usually affects the skin, mucous membrane, eyes, genitalia, and central nervous system. This is the main involvement of the herpes simplex virus. The diagnosis is usually done by doing a DNA PCR in the CSF. It is best done after 3 days following symptoms. If you do very early, within a day or two, you might not come across DNA PCR positive. And it should be always done before starting acyclovir, because once you start acyclovir, the chances of getting DNA PCR positive is less. Never ever do an HSV IgM because it is notoriously unreliable. And if you do an MRI, if you find bilateral temporal lobe involvement, then also it is a pathognomic of herpes simplex encephalitis. So here you can see there's bilateral involvement of the perisylvian and temporal region, which is almost pathognomic of herpes simplex encephalitis. And this is the case of herpes simplex encephalitis we had in a hospital. If you see, examine very carefully, he's showing involvement of the eyes, there is involvement of the mucous membrane, and there is skin rashes. The characteristic skin rashes of herpes simplex is clustering of the skin rashes. It is never seen diffuse as like other viral infection. It is clustering of the rashes. We diagnosed very early and we have given alcyclovir, and this is the result that the child is now able to sit up and eating from the mother. So herpes simplex encephalitis, if you start acyclovir right in time, you are going to save the child. So another very important differential diagnosis, strep typhus, is very common these days. Often they present with encephalopathy. Can it be strep typhus? I have taken two important studies, in fact, three important studies, and these were published in Indian Pediatrics 2018 and Indian Journal of Critical Care Medicine. Provash published this study. In a multi-centric ICU study, it was done in all four quarters of the country, and 30 cases of ICH Kolkata and 48 cases of CMC Vellore. Encephalitis was fairly common in all these cases. Rash was also there, and splenomegaly was there. And ultimately, if you see what are the principal presentation of strep typhus, the first six, that is hepatosplenomegaly, rash, encephalopathy, generalized edema, generalized lymphadenopathy, and respiratory distress. These are the common presentation of strep typhus. And to diagnose strep typhus, there is no pathognomic signs and symptoms. You have to have this mind and you have to be aware. And nowadays, these IgM antibodies can be done. So diagnosis of strep typhus has become easy nowadays. And if your suspicion of strep typhus is very high, even if you don't have the facilities to diagnose, you are well justified to give doxycycline on the basis of suspicion. It has been endorsed by the American Academy of Pediatrics. So the another encephalitis which has baffled us for last 2 decades, for last 20 years, every year from the March to July, small children in Bihar, especially around Muzaffarpur, and also this is the lychee growing belt of Bihar. Every year, quite a good number of children either they die from this encephalitis or they those who survive they leave behind a serious disability. Three agencies, one national center for disease control studies in India, one USA CDC, and one local Sri Krishna Medical College studied this encephalitis in what occurring in Bihar. And everyone has something different to suggest. One group suggested that lychee contains hypoglycine A and methyl cyclopropylene glycine. These are substances which prevents neoglucogenesis. And already these malnourished children of Bihar, they have very little glycogen stored, and often they skip the night time food, that is dinner, and they develop early morning hypoglycemia. And because medical facilities are not there, by the time they receive glucose, it is too late. Either the patients die or they develop irreversible damage. But again, Sri Krishna Medical College has suggested something else. They have suggested because of extreme heat and extreme degree of sweating, these children died from dehydration. So ultimately, there are many theories. One, somebody told heat stroke, somebody told hypoglycemia, but the amount of MCIG in the lychees is not that high. So ultimately, the result was that 5 or 6 men examining the elephant, and we could not find the exact cause. And now a team of doctors from AIMS is conducting the detailed study and hope we'll get the reason for this encephalitis. So the cause of this encephalitis is not known, but one very sad thing has happened about this. People started taking lychees, and the farmers of Bihar who have grown lychees for generation suddenly found that the market of lychee has come down, and not only the child is dying from this encephalitis, the farmers are dying from starvation because they cannot sell their product. So another very important thing is that can it be typhoid encephalopathy? What are the common presentation of CNS involvement of typhoid? And I'd like to say a few words about steroids in typhoid encephalopathy. And what are the recent development in resistance of Salmonella typhi in recent years? A state of confusional toxicity or confusional delirium developing in the 3rd week of typhoid fever, known as coma vigil, is a memorial of pre-antibiotic error. Those who developed coma vigil, the outcome was invariably fatal. But fortunately, nowadays, we don't see those cases. Most cases of typhoid encephalopathy which we come across is usually seen between 5 to 7 days. They usually present with confusion, delirium, slight degree of psychosis, raised intracranial tension. And I was searching the literature to find what might be the uh, percentage. 2 studies I came across, both the studies were from Bangladesh, very old studies, one in 2012, another in 2005. And they have shown that 21% in one study and 3 to 35% in one study typhoid develops encephalopathy. we have treated innumerable cases of typhoid, and we don't get that amount of encephalopathy. It is much, much less. And another very important thing, if you look at any textbook of pediatrics, you will find if the child develops typhoid encephalopathy, they have asked to give in dexamethasone at a dose of 3 milligram per kg. 3 milligram per kg followed by 1 milligram per kg every 6 hours for 48 hours. I was trying to find the reference, and this reference dates back 40 years. For 40 years, same thing has been written in all the textbooks. And think of the huge dose of dexamethasone. Are you justified to give this dose? And if you give this dose, a very important thing will happen. You are going to mask another important complication of typhoid, that is intestinal perforation, and you will hasten the bleeding from the typhoid ulcers. So never ever give dexamethasone in these doses. We have treated so many typhoid cases, we have to give dexamethasone. And even if we have given dexamethasone, we usually give in original doses. Now coming a little back to the resistance pattern in typhoid. In the first decades of 20th century, there was no drug against typhoid, and the disease was mainly in children and young adults, and the mortality or the case fatality rate was as high as 50%. COVID has a case fatality rate of 3 to 5%, and here typhoid has a case fatality rate of 15%. It was in 1940s, a doctor known as Theodore Woodward. He's not the Woodward of Gripewater fame. Theodore Woodward was working in Malay Peninsula. Malaysia had numerous rubber plantation and where scrub typhus was rife. So he was trying to find a cure of scrub typhus. Suddenly he discovered chloramphenicol. Chloramphenicol didn't act against scrub typhus, but it has done miracle against typhoid. And along with chloramphenicol, two another antibiotics are already discovered almost at the same time. One was ampicillin and cotrimoxazole. The case fatality rate from 15% dropped down to 1%. Then 50 years down the line, suddenly Salmonella typhi acquired the genes which were resistant to all these three first-line drugs, chloramphenicol, ampicillin, and cotrimoxazole. So we came across multi-drug resistant typhoid. Fortunately, in that time, fluoroquinolone was available, but promiscuous use of fluoroquinolone, suboptimal dose, subtherapeutic timing had led to fluoroquinolone resistance within 1 year. Then we came across from multi-drug resistant typhoid to multi-drug resistant plus fluoroquinolone resistant typhoid. And for this, we have two important drugs. One is ceftriaxone, to be used in those typhoid patients who are hospitalized, or azithromycin, to be used in those patients which are treating from the outdoor. But then in 2018, a paper was published from the Sindh province of Pakistan, which has shown that the Salmonella typhi has acquired resistant genes not only against first-line drugs, but also against fluoroquinolones and ceftriaxone, and through transposins or jumping genes. And they were only susceptible to carbamazepines. And all of you know the carbamazepines are very costly drug. They are beyond the reach of ordinary people. So for these typhoid, they are known as XDR typhoid or extensively resistant typhoid. XDR typhoid, we have only one drug left. Either it will be azithromycin, but azithromycin cannot be given in very serious patients who are admitted in the hospital. For them, we are left carbamazepines. But only time will say whether this XDR Salmonella typhi can replace the concurrent Salmonella typhi, and whether they have capability to cross the international boundaries like COVID virus. Until then, fortunately, in our country, still now, Salmonella typhi is still responsive to ceftriaxone. So next thing that which comes in our mind, what is Nipah virus? So this is something a relatively new virus. To understand Nipah virus, you should little bit look at the mode of transmission. This is the date palm. Date palm is khejur. And in Bangladesh and adjoining part of West Bengal, the farmers, what they do, they tie earthen pots in the date palm plants in the evening so that the whole night the nectar or the juice accumulates and they consume the juice raw next morning. During the night time, these nocturnal bats, they come and they take this juice and they infect the juice with their saliva. And when the saliva infected this date palm juice is consumed by human beings, they develop Nipah virus disease. There is also another second mode of spread. The fruit eating bats, they they cause some of the half eaten fruits falls in the ground and they are taken up by the pigs. And if somebody consumes undercooked pork, then they develop also Nipah virus. And the third way of spreading of Nipah virus is by droplet transfusion from human to human. So these are the three ways of spread of Nipah virus. And again, Nipah virus has an initial symptoms just like dengue, fever and muscle pain, and to be followed by symptoms of encephalitis. It causes a diffuse inflammation of the brain and it is a highly fatal disease. The case fatality rate is as high as 40 to 75%. So fortunately, that Nipah virus, it has stopped these days and fortunately we don't get Nipah virus that much. So next, another very important thing which has hit the market is the Chamki Bukhar. What is Chamki Bukhar? Chamki Bukhar is not a disease. It has been, it has a term which is coined by the newspaper people or the media people. Any fever which comes with convulsion is known as Chamki Bukhar. Though there were agencies which investigated what might be the reason of Chamki Bukhar, and they found out there's nothing called such anything called Chamki Bukhar. It is nothing but a media reported any fever coming with convulsion is Chamki Bukhar. So coming back to our case, which we left long behind, the DNA PCR of the CSF has come. It is negative for HSV, but it was positive for IgM viral antibodies against Japanese encephalitis. And the MRI showed hyperintense, symmetrical hyperintense involvement of bilateral thalami, parieto-occipital cortex, and dilated ventricles. So this is definitely a Japanese encephalitis. And how do we diagnose Japanese encephalitis? We usually don't do a DNA PCR in case of Japanese encephalitis. Rather, we see IgM antibodies in the CSF. Also, you can see IgM antibodies in the serum. IgG antibodies we never do because it is useless, because you need to have a four-fold rise, which can be done only in theoretical or research purpose. Antigen detections are there, but we don't do, and virus isolation is out of question. Another very important thing, I told you every devil has his own den. Japanese encephalitis usually involves the thalamus and adjoining parts of the brainstem. So MRI lesions in the thalamus, basal ganglia, and midbrain usually identifies Japanese encephalitis. So this is how a Japanese encephalitis is transmitted. It's a very important one should understand. Egrets. Egrets are waddling birds, usually who stays in water. Egrets and herons and the pigs, they are amplifying host. What do you mean by amplifying host? In amplifying host, the virus can multiply, often reaching to very high level. But the amplifying host will never develop the disease. And if a Culex mosquito bites the amplifying host and bites a human being, often it is children, then you have Japanese encephalitis. So what are the epidemiological and clinical clues? The first important clue is it is a viral disease which is transmitted usually by Culex mosquito. There are certain things which you require for Culex mosquito. First of all, you must have these lush green vegetables. The Culex mosquito, they take rest during the daytime. and they take rest in the shades of these lush green leaves. These are nocturnal biting mosquito. They can travel few kilometers for their blood meals, and they are zoophilic mosquito. That means they love to bite animals. They don't usually bite human beings, and they need plenty of water stagnation to lay their eggs. So this is the right setting. So it has been told that Japanese encephalitis is a disease of rural areas, because in rural areas you have this vegetation, plenty of water logging, and they are zoophilic mosquito. You have many animals, cattle and pigs. So at the night time, they usually go to bite the cattle and pigs. By cattle, we mean cows, ox, and horses. In cows, oxes, and horses, though the Japanese encephalitis occur, but they never attain viremia to that degree to cause transmission of disease. So it is due to accidental bite, when where animal and human being stay side by side. Instead of biting the animal, the mosquito bites the human being. That is how the disease is transmitted. But nowadays, a thing has changed. It has been seen that Japanese encephalitis not only occurs in the rural areas, it has been reported from Trivandrum, Chennai, parts of Hyderabad, Kolkata, Patna, Ranchi, Lucknow, Goa, even from Delhi and Bangalore. So what we thought that it is a disease of rural areas is not true. Might be it also involves the urban areas. So it is mainly the children who develops the disease, but fortunately it does not spread from child to child. Why it does not spread? Because in human beings, the viral never attains that degree of viremia to transmit the infection. And also not from cattle to humans, because again, in cattle also the virus never attains that degree of, does not multiply to that degree. It has been seen, if the number of cattle increases as compared to the pigs, there will be no transmission of Japanese encephalitis, because the mosquito is going to bite more of cattle rather than pigs. So the transmission rate of Japanese encephalitis comes down. But again, all these things are questioned nowadays. It was a disease of children, but now it has been seen that the median age of Japanese encephalitis has increased to 13 years. So it is more in older children rather than small children. And next we see, previously it was told that it is a Quilex mosquito, but now it has been seen Japanese encephalitis is also being transmitted by Anopheles, Aedes, and Mansonia mosquitoes. And also, not only it is the pigs and water birds, it has been seen that Japanese encephalitis can be also transmitted by these animals also. So these are the new things what are coming. So what are the clinical manifestation of Japanese encephalitis? Whenever you talk of manifestation, whenever anybody asks you any manifestation of any encephalitis, you should answer, I think, in three. The manifestations of infection, manifestations of raised intracranial tension, and manifestation of encephalitis. Manifestations of infection is high fever, malaise, muscle pain. Manifestation of raised intracranial tension is headache, uh, sixth nerve palsy, pupillary abnormalities. And manifestation of encephalitis is abnormal movements, because it involves the uh, this basal ganglia. It can involve the uh, multiple cranial nerve nucleus in the brainstem, so it can cause cranial nerve palsy, it can cause paralysis, and it can cause other features of encephalitis. So these are the common features of Japanese encephalitis. Now, what is the outcome of Japanese encephalitis? As we have compared two very important cause of acute encephalitis syndrome, two important cause which heads the list is Japanese encephalitis and dengue. If you see the case infection ratio, what do you mean by case infection ratio? Whenever you are seeded or you are infected by a virus, not necessarily you will develop the disease. In case of Japanese encephalitis, out of 250 being infected, only one will develop the disease. What will happen to the rest? The rest will develop immunity against the disease. What is the case infection ratio in case of COVID? If it is a family transmission, the case infection ratio is very high, 75%. So Out of 10, 7 will develop the disease, 3 will escape. But in case of Japanese encephalitis, the case infection ratio is very low. Vis-a-vis, if you take dengue, in immune subjects, out of 100, 1 will develop the disease. Whereas in Japanese encephalitis, more common in children, but dengue is common in all ages. And if you see the case fatality in Japanese encephalitis, the case fatality is as high as 20 to 50%. In case of COVID, the case fatality is only 2 to 3%. And in case of dengue, if you have a proper supportive treatment, the case fatality is less than 1%. And what is residua? The sequelae in Japanese encephalitis is very high, very common, whereas in dengue it is low. So, so if you see what is the outcome, 30% of the dengue patients will escape unscathed. They will have not have anything. 40% will die and 30% will leave behind severe neurological sequelae. Not only neurological sequelae, but they might also leave behind mental sequelae and neuropsychiatric sequelae also. So coming back again to our case, the convulsions were stopped with using valproate and levetiracetam. The child was having dystonic posture very frequently. Temperature settled after 2 weeks. Had an episode of aspiration pneumonia, but we failed to establish a feeding. Was on tube feed till discharge. Made no meaningful response, no vision, no hearing, and discharge after 20 days, almost vegetative. So the take-home message is standard care can prevent death, but cannot prevent morbidity. So here lies the importance of vaccines against Japanese encephalitis. So make sure West Bengal belongs to the Japanese encephalitis bed. Every child should receive this vaccine, and this vaccine is relatively cheap. So what are the different vaccines available for Japanese encephalitis? One is a live attenuated vaccine, which is known as SA14-14-2. It is the name of the strain which was isolated from a Japanese encephalitis patient in China. The vaccine is attenuated, it is live. By attenuation, we mean we culture and subculture the virus so that it loses its virulence but retains its immunogenicity. The same virus was taken up by an international company, Exiro, and this virus was grown in the kidney cells of the vervet monkeys. Hence, it is known as varicose-derived virus. Then it was inactivated, or the virus was killed by adding formaldehyde, and a vaccine was developed. Another virus, a vaccine is developed by isolating the Japanese encephalitis virus from a Indian patient in Kolar district of Karnataka. And this virus was isolated, and this virus was developed in the National Institute of Virology in Pune. And again, this virus was grown in the kidney cells of the barbet monkey, and it was inactivated or killed by adding formaldehyde. So these are the 3 vaccines we have in our country. But this live attenuated vaccine is only supplied in the government sector. We don't have any access to this vaccine. So for us, these are the 2 vaccines. So what should be the recommended doses? Japanese encephalitis vaccine should be given starting from the age of 12 months or 1 year. 2 doses should be given 4 weeks apart. And if any child misses this dose, you can give catch-up vaccine till 14 years, 11 months. And again, 2 doses of vaccine 28 days apart. There's a confusion whether 1 dose or 2 doses should be given, but the confusion has been settled. According to the IAP, 2 doses. According to the National Immunization Institute, NTG, 2 doses. According to WHO recommendation, 2 doses. So do we require booster dose of Japanese encephalitis vaccine? Currently, there is no recommendation, though certain international agencies do recommend to give a booster dose. Now I'll come to what is new in Japanese encephalitis vaccine. You know, Japanese encephalitis and dengue are both flavivirus. So does Japanese encephalitis vaccine induces a cross protection against dengue virus? Let us see little bit. Both the Japanese encephalitis and dengue, they belong to the flavivirus group. They share genetically and antigenetically very closely related. 53.5% of the amino acid sequence in the envelope protein is similar in Japanese encephalitis and dengue. and both these diseases usually co-exist, co-circulate in all the places. So this is the envelope protein in which 54% of the amino acids they share. And now I'll show you another very important thing. This is the dengue belt. It starts from Indonesia, Malaysia, Philippines, Cambodia, Vietnam, and even China. They have dengue. And in China, all the children, they receive Japanese encephalitis vaccine. During a dengue outbreak in 2010, it was seen that as Chinese children received Japanese encephalitis vaccine, dengue was very severe in all these countries. But in China, dengue was not that severe. So a thought was there generated during that period whether whether Japanese encephalitis gave some protection against dengue also. It was seen that cross-reacting antibodies in person who received Japanese encephalitis vaccine against dengue, not only antibodies, those people who received Japanese encephalitis vaccine, they showed cell-mediated response to again dengue virus. But unfortunately, the picture was not that rosy. Ultimately, at the end of the day, this protection was not at all consistent, and this didn't give protection to all the 4 serotypes of dengue virus. So the thing which had come with much delight now has fallen apart. So with this, I thank you for your patient hearing. End show korbo?
And Shokar.
বেরিয়ে যাবো শেয়ার স্ক্রিন, টপ শেয়ার করলাম।
এক্সিট শেয়ার করুন।
স্টপ শেয়ার আছে, এক্সিট শেয়ার করলে
একই তো, স্টপ এক্সিট।
হ্যাঁ। If anybody has any questions, I can answer.
আমার একটা কোশ্চেন হচ্ছে, you said that after 3 days you check the herpes simplex.
First 1-2 days a chance কম।
No, but does it mean that a patient comes to me and because they will come to me on day 1, the moment they have neurological symptoms, they will come to you, and does it mean that you will wait for
herpes simplex virus has a little bit of subacute presentation, unlike the catastrophic presentation in Japanese encephalitis.
It can have any presentation, it can be very slow.
Have, but usually it has
because very slow also,
because it takes some little time. So if you suspect very high, because what I have said, this herpes simplex virus not only involves the brain, it involves the mucous membrane, it involves the skin, it involves the genitalia. The child I have showed you presented with skin rash, conjunctivitis, and oral ulcers. So here, even if you didn't have any CSF positivity, you jolly well you are justified to treat with isaclizine.
How many cases of herpes simplex encephalitis you have seen with the skin lesions?
No, not many cases. Many cases.
And the skin lesions that you showed, is that they are not coalescing type of lesion. They were isolated, and the classic ones, one merges with the other. So ektar sathe arekta lagte jay. But the lesion that you showed is not the coalescing type of lesion.
Coalescent type of এটা confluent lesion হয়, মাঝখানে
confluent মানে একটার সাথে আরেকটা লাগতে যাবে।
মানে
clustering এটা বলে, তোমার যেটা ছিল that was not the type of lesion.
না, এটাকে বলে clustering of lesion, এটা কিন্তু ছিল ওখানে clustering of lesion.
Sir, I have seen total till today 7 cases of confirmed DNA PCR confirmed herpes simplex encephalitis. Among these 7, 6 of them had some sorts of mucocutaneous manifestation. Including this case.
You have to look
Only
for it.
one case we did not have any mucocutaneous manifestation. All of them, either preceding the illness or during the illness, we all had some mucocutaneous manifestations. And all except this case that Kundu sir has shown, all of them had a severe neurological features, and all of them, though treated early, had some sorts of sequelae, specifically in the hearing and speech.
That's herpes simplex, if given treatment early, and if given treatment not for 14 days, actually you have to give for 21 days. If you cannot demonstrate 2 subsequent DNA PCR negative. So if you do really give them proper treatment, they improve.
It is 21 days. There is no question
21 days.
of
আমি
No
তাই
question of
বলছি।
anything
14
less
days.
than
হ্যাঁ,
anything
14
less
days
than
না।
21 days is no. There is no question of anything less than 21 days.
না তুমি যদি পরপর দুটো দিন ডিএনএ পিসিআর নেগেটিভ দেখাতে পারো তাহলে হয়তো আগে
No. 21 days in herpes simplex encephalitis is 21. There is no question. Anything
what are the manifestation of scrub typhus other than encephalopathy? What are the different types we come across? আমি তো দেখেছি skin rash, hepatosplenomegaly, lymphadenopathy, respiratory distress. Is there any other manifestation of scrub?
No, anything is that in this season, whenever you're getting a patient
এটা
of
তো
AES,
তোর স্টাডিটা জার্নাল অফ ক্রিটিক্যাল মেডিসিন যেটা বেরিয়েছিল সেটা
AES
I
is,
think one should give a doxycycline in any encephalitis
yes.
before you can
This is now
confirm that
না
last
না
year.
doxy
Sir,
এই
last
প্রভাস,
year
take care of.
তোদের ক্রিটিক্যাল মেডিসিন বলছে নাও টাইম ইজ নট ইয়েট রাইট, ডোন্ট
No, sir. In 2018, we made the protocol, state protocol for acute encephalitic syndrome or undifferentiated fever with encephalopathy. 2018 state protocol. I was a member of the state protocol,
স্টেট
and we have universally given, started giving doxycycline for any undifferentiated fever with encephalopathy.
আমাদের
See, Prabhas, see, there are two causes. Firstly, scrap typhus is a very important cause, and there is a good treatment for that is the doxycycline. And about mycoplasma, we really don't know that because in California encephalitis project, mycoplasma was one of the most common cause of the problem. But we don't know whether it is just an immune reaction or it's an infection. But still, people will try to treat that. So if I give doxycycline, that will take care of your mycoplasma and also scrub typhus. So I will definitely give doxycycline to any encephalitis patient till my reports comes back, because you cannot wait. দুদিন পরে patient আরো খারাপ হয়ে গেল. You cannot take risk about brain, because once it is damaged, it is damaged.
So না একটা মানে how to distinguish between mycoplasma causing direct damage and mycoplasma causing immune mediated damage? If the encephalitis starts within few days of the onset of fever, most likely it is the bacteria which causes direct damage. But if the encephalitis starts after say about a week or 10 days after the manifestation of fever, the most likely it is immune mediated. In case of immune mediated mycoplasma, there's no point in giving antibiotics. I think there might lie different.
See, you cannot, if you have managed the patient, you cannot really differentiate between these two. And PCR in mycoplasma in CSF, the percentage is from anything below 0 to 14%. So you cannot take a risk. You will have to cover mycoplasma, and you will also have to cover scrub typhus. And once the report comes, in some centers, we have given anti-malarial also.
Yes.
Say in the middle of the night, I cannot do anything. I will give anti-malarial. Next day morning, I must stay.
তাহলে ceftriaxone, acyclovir, vancomycin plus doxycycline.
Oh yes.
না এখন তো vancomycin তো দিতেই হবে. Now তো you have to give vancomycin because most of the meningitis strain of pneumococcus are resistant to ceftriaxone. Quite a good number.
There are a few features that if your patient presenting with only neurological features, then it can be HSV. But if the patient presenting with some other features, like some respiratory distress is there, some pulmonary edema or pneumonitis features are there, count on the lower side, there are hepatosplenomegaly, scar, gas, CRP is very much high, albumin is very much low, SGPT, SGOTB elevated, then possibly you are not dealing with herpes simplex encephalitis. So in these features, if these features are present, possibly you are dealing with scrub typhus. And contrary to the popular belief, scrub typhus is also common in infant. 4 days back, we got the youngest scrub typhus of ICH. This patient was 38 days old, presented with a refractory seizure with a fever. Admitted in the ARI, came in a very bad condition in the PICU. At the time of admission, I asked that it is maybe a scrub typhus, loaded with doxycycline. And the child expired after 4 hours of admission to PICU. And scrub typhus ultimately came out to be positive in the next day. The 38 days old kid.
এইটা জানা জানা
তুই ডক্সিসাইক্লিন দিসনি?
হ্যাঁ দিয়েছিলাম একদম, আমি ঢুকেই সঙ্গে সঙ্গে ডক্সিসাইক্লিন দিয়েছি। ফার্স্ট থিং আই হ্যাভ গিভেন দ্য ডক্সিসাইক্লিন।
না তো অ্যান্টিবডি ভার্টিক্যাল ট্রান্সমিশন হলো না তো?
এই
অ্যান্টিবডি
প্রভাস এটা আমার কেসটা না রে?
হ্যাঁ 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 জানা জানা
প্রভাস
জানা জানা
প্রভাস ট্রান্সপ্লাসেন্টাল অ্যান্টিবডি পজিটিভ আসতে পারে।
IgM অ্যান্টিবডি কেন ট্রান্সপ্লাসেন্টাল?
এত ইয়াং এজে কেন রে স্ক্রাব?
IgM তো আসবে না
IgM স্টাফ পজিটিভ না।
স্ক্রাব ওয়ার্ডেও কিন্তু আমরা আগে 1 মাস কি 1.5 মাস বয়সে পেয়েছি আইজিএম।
38 ডেজের মধ্যে পাই আমরা। হাইস্ট পেয়েছিলাম মিমিদের একটা পেশেন্ট ছিল 2 months 3 days বিকজ উই আর ডুইং
অ্যাকিউট বা এ ছিল না, ওটা জাস্ট জ্বর ছিল এন্ড হেপাটোস্প্লেনোমেগালি আমরা করে তখন পড়তাম 2018-19 এ খুব বেশি আসতো, আমরা সব জ্বরকেই আমরা 5 দিন হয়ে গেলে স্ক্রাব টেস্ট করতাম এবং ওটারও পজিটিভ এসেছিল। তার জন্য আমার মনে হচ্ছে যে মেবি দোজ স্টিকস আর কামিং ইনসাইড দ্য হাউস এন্ড অর থ্রু দ্য ক্লোথস।
এটা মেদিনীপুরের পেশেন্ট ছিল, মেদিনীপুরের এটা ডিস্ট্রিক্টের পেশেন্ট ছিল।
ওই এখন আর ফিল্ড থেকে স্প্রেড হয় না, এই যে স্ক্রাব এই যে সুসুগামি ম্যাট্রেস থেকে হয়, তোষক থেকে হয়, তোষক না অ্যাকচুয়ালি জাজিম থেকে হয়, ওই যে ছোবার যে জাজিমটা হয় সেটা
রোডেন্টের উপরে থাকে।
না না ওই এটা সব
থাকে না, ওটা এখন থাকে না,
ওটা সুসুগামি থাকে না অনেক সময়, ওটা ওই জাজিম থেকে হয়।
জামা কাপড় নিয়ে চলে আসতে পারে বা whatever, somehow they are coming inside the house and it's not in the scrub vegetation.
Last according to the our PIC for the last 6 months of encephalitis.
আমাদের আরেকটা জিনিস যেটা কোশ্চেন আছে, হ্যালো
শুনছি, যে
তুই যেটা বললিস যে জাপানিজ এনসেফালাইটিস ভ্যাকসিন প্রোটেকশন দেবে, তো প্রোটেকশন যদি দেয় তাহলে দিলেও পার্শিয়াল প্রোটেকশন দেবে। আলটিমেটলি ইউ সে নো
না দেয় না কনসিস্টেন্ট নয়।
পার্শিয়াল প্রোটেকশন দিলে তো ডেঙ্গুটা আরো সিরিয়াস হয়ে যাবে, বিকজ
হ্যাঁ রাইট দ্যাটস দ্য রিজন ওয়াই এই যে ডেঙ্গু ভাইরাসটা লাইসেন্স পেলো না কেন, ডেঙ্গু ভ্যাকসিনটা লাইসেন্স পেলো না কেন?
তাহলে তো জাপানিজ এনসেফালাইটিসও প্রোটেক্ট
না আমি লিসেন টু মি, ডেঙ্গু যে ভ্যাকসিনটা ফিলিপিন্সে বেরিয়েছে সেটা লাইসেন্স পেলো না কেন? ইফ ইউ either you have to give vaccine by examining the antibody level. If your antibody level is negative, you take the vaccine, or if the general population should have antibody in more than 40% of the population, then you take the vaccine. এটা কি দেখাচ্ছে রুবি জেনারেল পার্ক, এটা কে, এটা কি দেখাচ্ছে? এটা
ওটা খেয়া দি
আমি
তো এই জন্য সেই জন্য ওয়ান অফ দ্য রিজন ওয়াই দিস ওয়াজ হয়নি যে এটা তো ইনকনসিস্টেন্ট, এটা মানে ইট ওয়াজ এটা জাস্ট
আচ্ছা প্রভাস
ইন্টারেস্টিং বলেছে এটা।
তোরা অ্যান্টিমকটা তোরা বিকজ ঋতুব্রত ডিডন্ট কভার
কত করলে অটোইমিউন
মানে অ্যান্টিমকটা তোরা সিএসএফ এ দেখিস না সেরামে দেখিস?
অ্যান্টিমক স্যার আমরা দেখি না খুব একটা, কারণ হচ্ছে যে
করলে কোথায় করবি, কোথায় করবি?
অ্যান্টিমকটা কোথায় করে বোধহয় জানি না, ওদের
আমরা মেইনলি তো
আমরা তো জানি
এনএমডিআর করি।
ফিউ ডেজ ব্যাক আমি একজনকে বললাম যে এটা সেরামে করতে, তো কেউ আমাকে যেটা বললো যে না এটা সিএসএফ এ করতে হবে। দেন আই ওয়েন্ট থ্রু সব জায়গাতেই দেখলাম সেরাম। আজকে বিকাল বেলাতে আমি ব্রজেশ সুগারিকে টেলিফোন করলাম, বললাম নো ইট ইজ অলওয়েজ ফ্রম দ্য সেরাম। The reason I'm telling you here that অনেকের একটা ধারণা আছে বোধহয় সিএসএফ থেকে বোধহয় অ্যান্টিমকটা করতে হবে।
অ্যান্টিমক and NMDR two different things.
NMDR কিন্তু সিএসএফ ও হয় সেরামেও হয়।
Yes, NMDR
দুটোতেই হয়।
NMDR দুটোতেই হয়। হ্যাঁ,
CSF is better,
কিন্তু অ্যান্টিমকটা সেরামেই করবে।
কিন্তু হয় না তো এখানে, কোথায় হয়?
কে বললো হয় না?
কোথায় হয়?
এই তো অনিরুদ্ধ আছে
না, অনিরুদ্ধ
পলিসে করে তোমার অ্যান্টিমক,
মেট্রোপলিসে
এতে করে, ঢাকুরিয়া আমরিতে করে।
আমরা মেইনলি আমাদের অটোইমিউন এনসেফালাইটিস প্রোফাইলে ঠাকুরটা আমরিতে পাঠাই, ওটা আমি একটু বলে দিলে
এই শুভজিৎ আমাদের একটা অ্যান্টিমক পজিটিভ হলো না?
হ্যাঁ, ওটা যেটা জোয়ার কেসটা পজিটিভ এসেছিল ওটা আমরা মেট্রোপলিসে পাঠিয়েছিলাম।
হ্যাঁ,
সেরাম থেকেই পাঠিয়েছিলাম, ওটা সেরামেই পজিটিভ এসেছিল।
হ্যাঁ, অ্যান্টিমক 2-3টে জায়গায় হয়, একটা বোধহয় আমরিতে হয় আর একটা মেট্রোপলিসে হয়।
ঋতুদা একটা চ্যাটে কোয়েশ্চেন আছে দেখুন না।
কোশ্চেনটা আছে, should we give empirical acyclovir in all cases of acute encephalitis syndrome?
Oh,
Yes,
yes.
yes, you
Yes.
should always give. Acha, now if you're clinical MRI wise not, যদি clinical MRI wise and CSF তিনটেই যদি নেগেটিভ হয়, you can withdraw it.
So anti-mock কিন্তু morely associated with Adam and Adam-like situations rather than autoimmune encephalitis.
কি
Anti-mock associated with
Adam.
anti-mock is positivity is mainly associated with anti-mock associated encephalomyelitis. Basically, Adam-like
না,
or
অনেকগুলো
Adam-like situation. It's not an autoimmune encephalitis. It's two different.
অনেকগুলো যেমন ধর অ্যাকুয়াপোরিনেও অ্যান্টিমক পজিটিভ হতে পারে। ইটস এ স্পেকট্রাম। আমি তোকে পাঠিয়ে দেব যে কোনটায় তোর অনেকগুলো 5টা 6টা আছে, ইভেন সাম ফর্মস অফ মাল্টিপল স্ক্লেরোসিস।
না স্যার, অ্যান্টি-মকটা কিন্তু অটোইমিউন এনকেফালাইটিস এর অ্যান্টিবডিজ গুলোর মধ্যে পড়ছে না। অ্যান্টি-মকটা পড়ছে বেসিক্যালি হোয়াইট ম্যাটার ডিমাইলিনেটিং ডিসঅর্ডারস, যেটা হচ্ছে অ্যাডেম
ডিমাইলিনেটিং ডিসঅর্ডারস এর মধ্যেই পড়ছে।
হ্যাঁ, ইটস নট আ অটোইমিউন এনকেফালাইটিস।
অটোইমিউন এনকেফালাইটিস তো অত ডিমাইলিনেশন হবে না।
ডিমাইলিনেটিং আর অটোইমিউন তো ডিফারেনশিয়েট করা সেই সময়টা খুব মুশকিল।
না,
সেটা করা যাবে না, তো মুশকিল।
আপনি এমআরআই তে যদি আমার হোয়াইট ম্যাটার ডিসঅর্ডারস থাকে,
সেইজন্য যে কোনো অ্যাডেমে এখন অ্যান্টিমকটা করে নেওয়া হয়।
অ্যাডেমে কি নিউরোসাইকিয়াট্রিক সিম্পটমস হয়, খুব কম হয়, এক্সেপ্টিং দ্যাট ইন্টেন্স হেডেক এন্ড পেইন। আর কিন্তু এটা অন্যরকম, কিন্তু
yes,
Adam is slightly different from the.
So clinically also autoimmune encephalitis spectrum and Adam spectrum.
অ্যাডেমে তো না ঋতুপদ যেটা বলছে, অ্যাডেমে তো তোর এনসেফালাইটিক কম্পোনেন্ট থাকতেই হবে।
হ্যাঁ, এনসেফালাইটিস থাকতে হবে, কিন্তু সাইকিয়াট্রিক ম্যানিফেস্টেশন রিলেটিভলি কম। আমরা যত এনএমডিআর দেখেছি ওগুলো সবকটাই সাইকিয়াট্রিক ম্যানিফেস্টেশন।
প্রবলেম এনএমডিআর এ বেশি হয়, এনএমডিআর এ বেশি হয়,
যেটা হচ্ছে
এনএমডিআর এর ওটার বয়সটাও তো একটু বেশি।
না,
autoimmune
encephalitis, whether it may be NMDR or VGKC or any other antibody associated, the characteristic feature is that MRI is most of the times is normal or some subtle findings excluding the white matter areas, specifically the hippocampal or temporal or
limbic এরিয়াতেই ও বেশি ধরে। আর
কিন্তু MOG associated or aquaporin associated syndrome, there are predominantly white matter involvement that is very obvious on MRI. So একটা পেলাম মানে তাকে আমি ব্ল্যাঙ্কেট মগ এনএমডিআর সব পাঠিয়ে দিলাম, সেটা কিন্তু নয়। these are very much costly, so you need to select patient যে কাদের আমি মগ অ্যাকুয়াপোরিন এনএমও গ্রুপটাতে ভাববো, অ্যাডেম গ্রুপটাতে ভাববো, আর কাদের আমি অটোইমিউন এনকেফালাইটিস গ্রুপটাতে ভাববো। we cannot send blanket, that the message should be percolated to the PGs.
So what is the purpose of sending for MOG? I think MOG is mainly for prognostication, because if there is a heavy high chance of
relapse and long term immunosuppression mainly
relapse এর জন্য।
ঠিক আছে, ভেরি গুড।
আরেকটা কোশ্চেন কি জানো ছিল?
দুটো জিনিস about the herpes simplex encephalitis. Two things. First thing is the doses. Most of the PGs are very much confused about the doses. The doses less than 1 year is a 10 milligram per kg per dose TDS. From 1 year to 11 year, it is per meter square. It's not the per kg. It's a 500 milligram per
500 milligram per meter square
per dose TDS. And after 11 years is a 10 TDS. So it's not the blanket 10 TDS. Number one. Number two.
প্রভাস, কিন্তু ইংল্যান্ডে যদি তোর below 3 months হয়, the dose is 20 milligram
per kg, double dose,
not 10 milligram as you say, it's 20 milligram per kg. And the other thing that we don't follow is also যে আমরা herpes simplex encephalitis এর পরে একটা prophylactic dose continue করতে।
Exactly, ওটাই বলতে যাচ্ছিলাম, prophylactic for 1 year.
Prophylactic dose in herpes simplex, in neonatal herpes simplex, always you have to give a prophylactic dose. মানে কিন্তু এইটা কিন্তু এখনো অনেক কিন্তু অনেক জায়গায় আসেনি। Actually herpes simplex, once you harbor, you will harbor it rest of your life. You cannot eliminate.
It is coming up, herpes, valacyclovir for 6 months. valacyclovir for 6 months following herpes, এটা আসছে এখন, পুরোপুরি কোনো রেকমেন্ডেশন আসেনি, কিন্তু আসছে।
রেকমেন্ডেশন আছে, আমি ইংল্যান্ডের রেকমেন্ডেশনটা তোকে বলছি যে যদি তোর 3 months, birth to 3 months দিতে হবে for prophylaxis of HSC recurrence. যদি immune competent হয় তাহলে তোকে 3 months আর immune compromised হলে 12 months দিতে হবে।
আর বলছি risk মানে better prognosis neurological outcome after
আমি বলতে পারি that we have started giving the acyclovir prophylaxis for all the confirmed cases of HSC encephalitis for the last 2 years. We got 3 cases for last 2 years. These patients have less episodes of breakthrough oral, facial, mucocutaneous and genital herpes. But previously that we had 2 or 3 cases of HSV. These patients are coming up to me in the OPD repeatedly every 3 to 4 months with repeated episodes of herpetic gingival stomatitis. We have not given prophylaxis to this.
Any herpes will have recurrence always because the hallmark of herpes infection is recurrence. But if the recurrence is very much nuisance causing, then only we subject the patient to a long-term even genital herpes. You can give it for 6 months. Oral herpes, every now and then you give it for 6 months. Once the herpes gets attached to your neural tissue, no amount of whatever medicine is going, you cannot remove that.
With regard to herpes, I would like to mention here herpes can increase the chance of autoimmune encephalitis later on.
Exactly.
A person can come with herpes simplex encephalitis and
herpes simplex encephalitis is one of the most common cause of autoimmune encephalitis. Number 1. Number 2, lower the age. The gap between herpes simplex encephalitis and starting of autoimmune encephalitis will be less. So this is very important. In fact, herpes simplex encephalitis is the most common cause of autoimmune encephalitis in children.
Especially NMDA encephalitis.
Yes.
As well as herpes virus type 6. These are the 2 viruses.
আরেকটা ভাইরাস যেটা ওই ইকোভাইরাস টাইপ 21 and 22 এটা এখন আরো একটু বেশি আসছে। আমি প্রোফাইল্যাক্সিসটা পাঠিয়ে দেব তোদেরকে। ঠিক আছে।
The post for them in group A.
Another thing is that dengue encephalitis. This is also not very much uncommon. You have seen few cases
dengue encephalitis and dengue encephalopathy, because hardly dengue is ever isolated from the neural tissues. It is mostly dengue encephalopathy.
Encephalopathy, dengue-টা encephalopathy.
Pathy, not encephalitis.
dengue-তে MRI changes-টা খুব বেশি পাওয়া যায় না।
না পাওয়া যায় স্যার।
পাওয়া যায়, কম পাওয়া যায়, কম পাওয়া যায়,
অনেক কম পাওয়া যায়,
আইসোলেশন কত হয় যায়।
আমাদের একটা কেস আমরা পেয়েছিলাম আইসিএইচ এ, ও বাইরে থেকে এসেছিল, 1.5 বছরের বাচ্চাটা, ও ডেঙ্গু হয়েছিল, লোকাল গভর্নমেন্ট হসপিটালে ভর্তি ছিল, ডেঙ্গু সেরোলজি পজিটিভ হয়েছিল, বাড়ি গিয়েছিল, আবার ও এসেছিল আমাদের কাছে with fever and convulsion and hemiplegia like that. So when the repeat MRI was done, the first MRI done in the government setup was normal actually. But the next MRI done, I think 3 weeks after that initial, that had very discrete round patches of edema. So as with any virus illness causing autoimmune things, so even I think here also dengue might also ultimately be shown to cause some autoimmune problems. But this is just one case that we saw.
ঠিক আছে, থ্যাংক ইউ এভরিবডি। সোমনাথ লিভ করছি।
থ্যাংক ইউ ঋতব্রতদা।
থ্যাংক ইউ
ঠিক আছে,
থ্যাংক ইউ স্যার।
থ্যাংক ইউ। এটা কি দেখাচ্ছি বলতো, রুবি পাবলিক স্কুল পার্ক।
স্যার এটা আমি
চলো টাটা।
থ্যাংক ইউ।
এর কম্পিউটার থেকে করছে বোধহয়।
তাই।
বাই।
লিভ হচ্ছে কেন?
লিভ করতে পারছো না?
হ্যাঁ দেখতে পেয়েছি, লিভটা আসছিল না, লিভ এসে।
স্যার মিটিং এন্ড করছি স্যার